Now, OCT is a non-contact, non-invasive biopsy of the retinal tissue where high-resolution scans are taken and they are represented as micron-scale tomographic image to help in precise diagnosis of the retinal tissue. Now, why do we need an OCT? This is a picture of a patient where even on careful retinal examination, it appeared like a macular hole. But on OCT, when OCT was done, this was actually a cystoid macular edema. So this cross-sectional analysis tool is an established role in variety of retinal disorders like vitreoretinal interface disorders, patients with macular hole, diseases of retina where there is macular edema associated, subretinal fluid, hemorrhages, fibrovascular proliferation, RPE, retinal pigment epithelium, and choriocapillaris pathologies. OCT is helpful in diagnosing these conditions, assessing the progression of these situations, deciding the management of various macular disorders, and also very effectively following up these patients after the treatment. OCT is a simple, quick, non-invasive, sensitive, and a very reliable tool for assessing these macular disorders. Now, coming to the interpretations, basics of OCT interpretation, one has to understand and know the normal OCT scan before knowing the clinical conditions. ये ज़रूरी है कि हम पहले नॉर्मल को समझें, तभी हम उसकी abnormal conditions को assess कर पाएंगे. So, this is a normal spectral OCT passing through the center of the macula. When you compare this macular OCT with the normal histology of the retina of the macula, you can demarcate and delineate almost all the layers of retina as seen on the histology. If you see this enlarged picture of the same macular scan, the innermost layer is the nerve fiber layer, then this is ganglion cell layer, inner plexiform layer, inner nuclear layer, outer plexiform layer, outer nuclear layer, and this is the external limiting membrane, and this is inner segment and outer segment junction of the photoreceptors. And the last one is retinal pigment epithelium. So any layer which is a membrane will appear hyperreflective, and where in the layers where there are cells and nuclei, they will be hyporeflective. Where there is plexus, like external, this is internal inner plexiform layer and outer plexiform layer, they will appear hyperreflective. So this is how a normal macular scan looks like. This is the international nomenclature for the OCT that was given in 2014. If you see this picture, you will see so many markers and names given here. But not to confuse a comprehensive or general ophthalmologist, I'll try to simplify this for you further. Now, if you filter out some of the not so important structure, the scan appears simpler. This is how the normal macula appears. The central depression here is the fovea or the foveal pit. Hyperreflective innermost layer is the nerve fiber layer. This is the nerve fiber layer here. This is thicker towards the disc side. As you see, this is another important receptor, inner segment, outer segment junction, and this is also known as photoreceptor integrity line, PIL. But the most common nomenclature for this line is ellipsoid zone. Then is the retinal pigment epithelium, and after that is choroid and then sclera. So, if you consider all those nuclei and plexiform layers as inner retina, and layer after the external limiting membrane as outer retina, I think this can take care of most of the diagnosis of common retinal disorders for a general ophthalmologist point of view. So you need to know nerve fiber layer, foveal architecture, external limiting membrane, retinal pigment epithelium, inner retina, outer retina, and choroid. And the most important is this ellipsoid zone. Variety of protocols are available. The width of the scan can be varied as per the requirement of the clinical situation. The radial scan is done at the center of the macula. There are chances of missing the lesion if you are doing a radial scan, but the advantage of radial scan is that it is quick and the resolution is slightly more than the raster scanning. If you don't want the lesions to be missed, then it's better you do a raster or a three-dimensional scan, where the scanning is done from above downwards of the macular area. There are no chances of missing the lesion in raster scanning. Now, what is the protocol for interpreting a macular scan? First, you have to see the scan quality. The scan quality depends on the strength of the signal, movements of the eye, media opacity, how good is the fixation and cooperation of the patient. But in a reasonable scan, you can still make out gross features to make a clinical decision. Next is the quantitative analysis. This quantitative analysis gives you an idea about the thickness and volume of the macular block. And then is qualitative analysis. In qualitative analysis, you see the contour of the macula. This is the normal contour. And then you see the vitreous, which is anterior to this. Is there any abnormality? There is any opacity in the vitreous. Then you see the vitreoretinal interface, inner retinal layers, which are these neurosensory layers. And then another important structure is external limiting membrane, photoreceptor complex, or ellipsoid zone. And then is this our retinal pigment epithelium. You cannot differentiate between Bruch's membrane and RPE in a normal scan unless the retinal pigment, there is a retinal pigment epithelium. Both these RPE and Bruch's membranes are merged together and they cannot be delineated on a normal scan. You can only see Bruch's membrane here when there is a detachment of RPE from Bruch's membrane. So now the lesions can be hyperreflective or they can be hyporeflective. The hyperreflective lesions can be hard exudates or hemorrhages. They are represented as the red or yellow colors in the pseudo color coding, and the lesions can be hyporeflective. The hyporeflective lesions can be edema, serous fluid, or sometimes the atrophic areas. So this is the pseudo color coding, which is given by the computer software. The hyperreflective lesions appear red and yellow in the spectrum, and the hyporeflective lesions, they appear blue and black towards the color spectrum. It is better to analyze a macular scan in a shades of black and white in a gray hue. But most of the reports that we see are in pseudo color coding, so that is why we are talking of the pseudo colors. In quantitative analysis, retinal mapping gives quadrant information of the macular area. It is useful in monitoring the response to any intervention. You have to see the central foveal thickness, the volume of the retina, and what changes are occurring in this volume, the volume change analysis. Now, this is the most common. Now, how do we interpret OCT report? This is one of the most common OCT report that is given by the Zeiss machine. And when you see this whole machine, you have to know what are these things. So this is actually the picture of the retina where the scan has been taken. And this is the area which has been scanned by the machine. These colors depicts the thickness in this area. If you see this bar here, this gives you an idea how much thickness is there in this green area. The yellow area means how much thickness is here, and based on that, you can decide which area is thicker and which area is thin in a gross way. Here, this is the EDTRS type pattern of macular thickness. This is the central 1 millimeter zone, this is 3 millimeter zone, and this is the 6 millimeter zone. Here you can see the values of thickness in this particular zone in different areas. The thickness of the macula, the thickness of the retina is assessed from internal limiting membrane, the innermost layer, and the retinal pigment epithelium anterior edge. So these are the values in different zone of EDTRS mapping. This is the same thing which is represented here again, is the thickness of retina macular area. These are the changes that you can see in the internal limiting membrane. This is the ILM map, and this is the map for retinal pigment epithelium. If there are any changes in retinal pigment epithelium, this map will show you there. Now, these are the scans that the examiner has put it here because of the relevance. This is the horizontal scan. This is the horizontal scan here passing through the macula. This is the arrow is showing the thickness at this point, and this is the vertical scan passing through the macula, and you can see this is the thickness here. The thickness here is 67 and thickness here is 446. These are various quantitative analysis feature values. This is central subfield thickness, tube volume, tube average. These are relevant for quantitative analysis to assess the follow-up of these patients. So this is in a nutshell about how a routine OCT report is interpreted. All the machines give the similar kind of pattern, but the representation is somewhat different. This is a three-dimensional visualization of the vitreomacular traction patient. In this, you can see how the posterior vitreous phase is attached to the macular center of the macula, causing traction on the fovea. So this is vitreomacular traction patient. Now, I'll quickly go through some of the disease or clinical condition where OCT has been done, and you can see how they appear on OCT. This is a patient of macular dystrophy. Here you can see the fovea is thin, and you can see the loss of ellipsoid zone and thinning of the RPE here in the central foveal area. So this is a patient of macular dystrophy. Another patient of atrophic macular dystrophy. Again, the fovea is thin here, and RPE, you can see the changes in RPE, irregularity in RPE, and there is loss of ellipsoid zone and external limiting membrane here. This is a patient of Best disease. You can see this blister kind of appearance and some vitelliform material here inferiorly. In Best dystrophy, you can see the separation of anterior and posterior RPE in this patient. This is another common condition that we see quite routinely is retinitis pigmentosa. As you know, retinitis pigmentosa is a disorder of degeneration of retinal pigment epithelium. You can see here that the RPE is thin here. There is loss of ellipsoid zone and loss of external limiting membrane here. This hyperreflectivity that you are seeing in the sub-RPE area is because of the more transmission of light because of the thinning of RPE. So this is retinitis pigmentosa. In dystrophy, OCT is helpful in giving information about the morphology and assessing the progression of these diseases. This is a patient of photic retinopathy where you can see outer lamellar macular hole, which is showing the disruption in the anterior RPE and photoreceptor complex here and some of the layers of inner retina also. This is another interesting condition of juxtafoveal telangiectasia. You can see this hyporeflective area. This is basically an area of atrophy. This occurs because of the loss of molar cells in the inner retina in response to the ischemia to the finer capillaries in juxtafoveal telangiectasia. Now, how do you differentiate between this atrophic, this hyporeflectivity of the atrophic area and hyporeflectivity of the cystoid edema patient? In edema patient, the thickness will be more, and whereas in atrophy, there will be only hyperreflectivity without any increase in the thickness. Now, OCT in vitreoretinal traction patients. This is a patient of vitreomacular traction. You can see the epiretinal membrane, and this is the vitreomacular traction. This is a pseudo hole kind of situation, which is causing a lamellar hole kind of appearance in vitreomacular traction patient. In epiretinal membrane, there are two patterns of adhesions are seen. One is focally adherent and the other is globally adherent. This is an example of a globally adherent epiretinal membrane. Here you can see the normal foveal pit contour of the macula is lost, and the membrane is causing the straightening of the contour of the macula. This is another patient of epimacular membrane with the vitreous schisis here and causing vitreomacular traction also at multiple points. OCT is a very useful tool for patients of macular hole. It has added to the knowledge of macular hole etiopathogenesis. It helps in confirming the diagnosis of macular hole and also the staging of macular hole. It is a useful tool for post-op follow-ups and prognosticating the surgical outcome in these patients. This is a patient of pseudomacular hole. Here you can see the epimacular membrane, which is causing the distortion in the contour, and it looks like an inner lamellar macular hole. But since there is no loss of inner retinal tissue, so this is a pseudomacular hole with epimacular membrane. This is a patient with full thickness macular hole here, and you can see this is the operculum, and these are some cystoid changes in the edges of the macular hole. Another patient with the macular hole, which is caused by the cysticercus cyst, the appearance is similar with some cystoid changes and full thickness macular hole. Central serous chorioretinopathy is a common disorder that everybody of us see, and in central serous retinopathy, it helps in diagnosing the structural changes that are happening. It reduces the need for angiography in these patients. Angiography is only needed when you are contemplating laser treatment for these patients. It helps in assessing the complications of CSER and is an effective and easy tool for following up these patients. This is a sad patient having simple central serous retinal detachment. Here you can see there is a neurosensory retina which is detached from this RPE. So this is serous detachment. There is separation of neurosensory retina from RPE. This is another patient which has both serous detachment and pigment epithelial detachment. Most of these patients of central serous retinopathy are associated with pigment epithelial detachment also. This is the blister of pigment epithelial detachment here. When you see the OCT, this is the area of central serous detachment, which shows the separation of neurosensory detachment from RPE here. And this is the pigment epithelial detachment. Here you can see the RPE is raised and there is fluid underneath. So both serous detachment and pigment epithelial detachment are here. You can see this line of RPE is raised here. This is of PED, and this is serous detachment. Now, this was a patient where of central serous chorioretinopathy. This is the leakage here, and after the resolution of this leakage, the vision did not improve in this patient. So the OCT was performed, and it was found that the OCT was the fovea was thin, and there was loss of ellipsoid zone, and there were abnormalities of the RPE, and that is the reason why vision did not improve in spite of the resolution of this leakage in this patient. So these are important biomarkers for assessing the prognosis of these patients. Now, the commonest disorders that we all see in retina practice is diabetic macular edema. OCT helps us in defining whether the edema is involving the center or is it not involving the center. Based on that, our management strategies are decided. Now, you can assess the retinal thickening on spectral OCT. The pattern of macular edema is also can be demonstrated on OCT, and you can see whether the edema is having cystoid edema or there is neurosensory subfoveal detachment. Is the macular edema associated with epiretinal membrane or vitreomacular traction? Based on the pattern of macular edema, the management strategies are decided in the management of diabetic macular edema. Another important thing is the biomarkers. You have to identify loss of ellipsoid zone, disruption of external limiting membrane, and disorganization of the inner retinal layer. Disorganization of inner retinal layer is also known as drill, and all these things are important for prognosticating these patients, outcome of prognosis in these patients. Now, this is an example of a diabetic macular edema patient. Here you can see the attachment of vitreous phase on the retinal surface. This is normal. Here you can see increased thickness because of the macular edema, some small cystoid changes, some spongy macular edema. These are hard exudates, which are hyperreflective. And you can see these this is the shadowing because of the hard exudates, and there is no abnormality here. If you see this patient, you can see the external limiting membrane and the photoreceptor complex layer or ellipsoid zone is healthy here. So if you treat these patients effectively, there are chances of regaining good vision in these patients. Another patient of diabetic macular edema. Here you can see the cystoid changes, spongy edema here. The thickness is more. These are hard exudates showing shadowing here. And you can see the ellipsoid zone and the external limiting membrane is intact here. So the chances of regaining good vision in these patients after the adequate treatment. This entity of subfoveal serous detachment can only be diagnosed on OCT. Before the advent of OCT, we were not able to diagnose this subfoveal serous detachment. And once you see this subfoveal serous detachment on OCT, this subfoveal serous detachment is mostly associated with the hypertension and proteinuria in patients of diabetes. So if you treat these systemic conditions of hypertension and proteinuria, there are likely chances that the subfoveal serous detachment will resolve. Once you see that this epiretinal membrane is associated with diabetic macular edema, the treatment of choice is surgical removal of this epiretinal membrane with vitreous surgery. One should avoid doing laser photocoagulation in these patients, and also anti-VEGFs are also not very effective in this situation. So the treatment of choice is surgical removal of epiretinal membrane. This is another patient of extensive hard exudates. You can see extensive disorganization of the inner retinal layer. You can say this is drill, and this is loss of ellipsoid zone and external limiting membrane throughout. So even if you treat these patients with whatever modality, there are chances that these patients will not regain any vision because of the loss of these biomarkers, which are very important to understand. Now, this is a patient of vitreomacular traction. Here you can see macular edema because of the vitreomacular traction here, and this can be very effectively, this has been very effectively treated with surgery. The fovea has taken a normal contour after 2 weeks of surgery. I can skip this slide. OCT is also useful in vascular block. This is the first line investigation in venous block. The findings in venous blocks are macular edema and serous detachment. And OCT helps in monitoring the treatment response in these patients. This is a patient of central retinal venous occlusion. You can see there is extensive macular edema here, and you can see this is the area of subfoveal serous detachment. And this is the response after the anti-VEGF injection. The thickness has reduced considerably. This is a patient of branch retinal venous occlusion. This is macular edema, and this is the response after the treatment. If you see this patient, there is hyperreflectivity here. Even after resolution, there is some hyperreflectivity here. This hyperreflectivity, sometimes you see in these patients when there is associated arterial occlusion in the superficial layers of the macula. Now, in the OCT in choroidal neovascular membrane or age-related macular degeneration is helpful in quantitative assessment of subretinal and intraretinal fluid. It assesses whether the CNVM is involving the fovea or it is extrafoveal, and its role is in adjunct to FFA and helps it better delineation of choroidal neovascular membrane. OCT in choroidal neovascular membrane helps in assessing the progression of regression of subretinal fluid, cystoid macular edema, or pigmented epithelial detachment. So OCT is a very useful tool in following up these patients. This is a patient with age-related macular degeneration, choroidal neovascular membrane. This is the hyperreflective choroidal CNVM here with overlying serous fluid here. This is another patient with the fibrovascular PED. You can see the pigment epithelial detachment here, and this is the choroidal neovascular membrane, and this is the overlying serous detachment in ARMD patient. This was a patient with pigment epithelial detachment here. This patient was treated with the Lucentis, and after 2 doses of Lucentis, the pigment epithelial detachment, the fluid resolved, but the vision did not improve in this patient. Why vision did not improve? You can see carefully there is loss of ellipsoid zone and external limiting membrane, and it has gone into geographic atrophy here. So this is, if you see this external limiting membrane and ellipsoid zone are absent, these are important prognosticating features of these disorders. Now, it is very important to know the idea about the artifacts to have an idea of in quantitative interpretation of the OCT scan. These artifacts can be misalignment, software breakdown, shadowing, blinking artifact, motion artifact, out of the range error, and mirror artifacts. It is very difficult to cover all these artifacts in this talk, so I'm skipping this. In this era of OCT, some people think that fluorescein angiography, ICG have no role these days, but OCT is complement this fluorescein angiography, ICG, and autofluorescence, etc. all are complementary to each other in making the precise diagnosis. These days, we are in Corona days, we are hearing this name HCQS very frequently, and it is considered that this HCQS is helpful in treating Corona patients. We know that this HCQS can cause bullseye retinopathy in patients who take this HCQS for prolonged period in high doses. OCT is a helpful tool in assessing these changes that may happen in retina following the use of HCQS, but they happen only on very prolonged use. You can see here that there is loss of external limiting membrane and loss of ellipsoid zone in the parafoveal area. So OCT can be very helpful in assessing these changes of HCQS toxicity. So in the end, I'll end my talk with this pratna in these days, which is very relevant. Sarve bhavantu sukhna, sarve santu niramaya, sarve bhadrani pashyantu, ma kashyat dukbhag bhave. Om Shanti, Shanti, Shanti. Thank you.
Thank you very much, Dr. Puneet.